Thank you very much for joining us. We're really excited to be here tonight. We both have a tendency to just sort of chat, so we're going to take it fairly easy, and then please just lots and lots of questions. We're really happy to answer anything. Now, the first part of this is a presentation, so I am going to share just my screen with you here. And so and just excuse me for a moment, I just need to do a quick rearrangement while we do a share. And you should be able to see my window hopefully here now. So what we're talking about is IVF Explained in conversation with Anusch Yazdani and Sam Coffer. So tonight we're really just going to talk about what fertility is all about, and we're going to try and demystify an IVF cycle. Now, what we actually don't want to talk about is what the reasons are why you may be running IVF, because I think that's a couple of hours by itself. So today we're just going to talk about how an IVF cycle runs and really how that's changed over the last few years, particularly with a little bit of direction around COVID in particular. So how does an IVF cycle run? Well, it's as easy as 1, 2, and 3, you know. So we're going to talk about these ones in sequence. Number 1 is how you prepare for an IVF cycle. Number 2 is the running of the cycle itself. And, you know, once you're on track, you're really just going. But number 3 is what you do after the cycle is over and where do we go. So number 1, preparing for the cycle. And I'm going to hand over to Sam over here because she's probably the best person to talk to you about how to prepare for a cycle.
All right, thanks, Anusch. Well, we know that the best way to prepare for any fertility cycle, but especially our IVF cycles, is to be in the best shape possible. So I don't mean physical shape, but I mean your health shape. So we know that having a healthy weight, so a weight within a healthy weight range for your height and size. We still use the old school BMI system in the medical world, despite the fact that we know that that's not necessarily always relevant to everyone, but it is something that for most people fall into that category quite well. We know that diet and maintaining a nice, healthy, balanced diet allows our body to be able to have the nutrients that we need, as far as our micronutrients, to be able to produce good eggs and good sperm. Also exercise, this comes into maintaining a healthy weight as well, but it also comes into play with helping maintain a healthy mindset throughout that IVF cycle as well. We do know that IVF cycles are not only physically draining for some people, but they are also mentally draining. So to be able to have an outlet where you can get those good endorphins up and get those feel-good hormones happening is also really important.
So what do you normally tell people? What's exercise? I'm going to ask you questions since we're here now. It's not interactive. So what do you tell people is good exercise? Is running okay?
Running's fine. Good exercise depends on what you're already doing prior to starting your IVF cycle. So we get lots of people that ask, can they continue doing their regular exercise? The answer to that is yes. If you're used to running 10Ks a day or cycling or doing your F45 classes a day, that is fine. What we don't want is we don't want people that have been sedentary and not doing anything for a long period of time to all of a sudden start ramping things up and thinking that they need to go for a 10K run each day. Slow, gradual increases if you're not doing any regular exercise is recommended, but don't just throw yourself into things because that will actually put your body into more stress, which can have an adverse effect on your hormones throughout the cycle. And then lastly, supplementation. So for our women out there, the number 1 supplement that we recommend is folic acid. That is by far the most important. And that is because it is the building block for the neural tube. And we start building that with nice healthy eggs.
Are there any particular types of folic acid that you need to take? Does it matter what brand it is?
It does not matter what brand you take. Some people will be a little bit sensitive to particular brands, and it can make them feel a little bit unwell, like any multivitamin. Once you've got one that works for you, as long as it's got at least 500 micrograms of folic acid, then it's perfectly fine.
Okay. How about smoking?
That's a no deal.
Oh, no.
So smoking,
alcohol, surely.
Alcohol, when we're in an IVF cycle, this is a little bit of a contentious issue depending on which specialist you talk to. We do understand that life does need to continue. So having the odd glass of wine here and there, if you're out at a party and you don't want people to know that you're undergoing treatment, is fine. It's not going to derail the whole IVF process, but we are trying to create embryos and we are trying to get pregnant. So what we stand by is try and reduce your alcohol to as minimal as you can, especially during that cycle.
I guess there are tricks that you can play, aren't there, when you don't want everybody, because that's always the one thing that people always ask, oh, why are you not drinking? Are you pregnant?
The old the old soda water with lime.
The lime, keeps them going. Coffee.
Coffee is fine to take. I think this is one of the biggest things. Obviously, if you're someone that has 6 coffees a day, we need to cut that right back down. But a coffee or 2 a day is totally fine to have whilst undergoing treatment. And finally, drugs. They're bad for you. They make you run around in your undies. If you look at this picture here on your screen, don't do them. And when we're talking about drugs, we're not just talking about illicit drugs that you buy on the street, but also things like steroids, which are also illicit, but things like that affect male fertility and also female fertility, as well as your partying drugs.
Okay, so that's preparing for the cycle. And now, how does the actual cycle then run in itself?
So there's a couple of different ways, but I think we're going to talk about the main way that cycles run. And so the main way that a cycle is run is once you've done all of your consultation with your treating team and you've got all the boxes ticked and you're ready to go, the first stage is calling on the first day of your period. Now, most units, I think, have of similar as to what is classified as day 1, but it is the first day of full flow before 12 midday. So if you are someone that spots for a couple of days prior to your cycle starting, that is not day 1. And if your period comes in the afternoon, again, the following day is day 1, but by all means, make contact with your team.
What if it's a long weekend like we've got coming up over here and it comes on Friday at 5:01, because that's usually what happens,
Usually what happens, yes, as we're trying to get out the door for a long weekend. That's okay. We will see you on the Tuesday when we're back. Monday? What day?
No,
whatever day we're
Friday.
back, Friday. And we'll get the ball started. Now, we'll talk about how things run, but provided that either your hormones are nice and what we call baseline, or your scan is nice and quiet, it's okay to start the cycle. It doesn't need to be started on day 3.
And so what we would then normally do is we'd give you a little plan like this, and this is just one of the plans. And the important thing here is that while you're reading, it'll give you an idea of what a cycle will look like. But in fact, how it runs on a day-by-day basis, your specialist is much better to give you some idea about, and will give you the details. So as Sam had said, normally people would call on day 1, and we'd normally see them in the first 5 days from the start of their cycle. And depending on where you're going at that stage, and we're going to talk about a GnRH antagonist protocol. So this is the one that's probably the most commonly run cycle in Australia. More than 80% of all cycles in Australia run like this. It means starting some injections, okay? And so these first injections are called follicle stimulating hormone because, funnily enough, they stimulate follicles, okay, and they make them grow. And so these are the ones that push out the eggs that are there for that month. Now, it doesn't take anything away from the future of your fertility. It just pushes out the number of eggs that are available in that month. And they're easy and they're straightforward. And I think most people don't have any problems taking those injections.
No, most people are fine. I think people that are going through their first cycle have a little bit of a freak out thinking that we just send them away with all of their medication. But usually they will come and sit down with myself or someone like myself. We go through their plan and do their first injection together. And 99.9% of patients are very surprised with how
easy it is.
intimidating the injections are.
Now, on the evening of the 5th day, we normally then start a second injection. And while the first injections, which are on top of the line over here, make all of the eggs come out, the second injection stops them from releasing because we don't want you to ovulate before we're ready to pick them up. So this is the standard protocol that most people would run in Australia. And this runs somewhere between 7 to 9 days of injections in order to get you ready. Now, how long really depends on how you respond to the treatment. An alternative may be to replace one of the injections with one of our long-acting drugs. And what that does is it replaces the first 7 injections, so it reduces some of the injections that you need to have. But in fact, the exact protocol that you would be taking would normally be dictated by your own special circumstance. And that depends on your age, it depends on your history, it depends on your hormonal environment. In the end, though, regardless of what happens, is the monitoring is always the same. And so this is us on Monday. Yeah. So IVF units are very much set up towards people who are working, who want to continue doing all of their work. And so Sam and I usually start at 6. In this particular day, we started at 5 in the morning. And the good thing about starting that early in the morning is you never any problems parking. Yeah. And so you just come to our rooms, and people are often worried about doing the scans and what that will look like. And it's an internal ultrasound scan. Yeah, it's easy. It's a women's health unit. So that's what everybody else is doing in this unit over here. And Sam and I then would normally do an internal scan where we have a look and see what the ovaries are like, see what the pelvis is like, what the lining looks like. It literally takes 3 minutes to do.
I think what's important to say there is a lot of women, when they call with day 1 and I say, okay, great, we'll see you for your scan tomorrow or the next day, have a little bit of a freak out because they do have their period. It is very, very normal. It is something that we deal with on a daily basis. It's a yucky feeling for yourself, but it's something that we do. And the reason that we do that scan internally is because it gives us the best view of what's happening with your reproductive organs at the beginning of your cycle. And that allows us to change your plan if we need to. So we might have an idea as to what we think we're going to do, but when we get in there on day 2 or day 3 of your cycle, and things might look a little bit different from a antral follicle count or an egg count, we may be able to increase or decrease your dose then and there and change things as we go along. So it just gives us a little bit more information than just abdominal ultrasound at that point in time.
Now, not all units do this. Some units do a blood test instead. We tend to do it like this because A, it avoids a blood test. B, you need to come in to pick up your drugs and medications anyway. And C, it means that we know exactly where it is and we can confirm your understanding. But actually how you started doesn't make so much of a difference. Certainly your subsequent scans, subsequent visits will normally involve an ultrasound scan, and exactly when and how many will depend on the unit that you see. Now, on the ultrasound scan, we're looking at the ovary. And so this is the ovary of someone who's actually had some stimulation for a number of days already over here. Now, you can see that the follicle, which is at the top of the scan, at the top of the image over here, that's the thing that's got the cross on it, and it measures 1.6 by 1.7 centimeters. So it's about 17 millimeters in size, so about the size of your thumb. Now, that started off being less than half of that size. So there were less than 9 millimeters before we even started. And so you can see that that makes the ovary get significantly bigger, and that gives some of the fullness that you see. Now, we want to grow them each until all the follicles in the ovary are somewhere between 18 to 20 millimeters in size. At the same time, we also look at the endometrium. So this is the lining, and this is where the pregnancy will be eventually. And we want to see that that's also growing in line with the hormones. So both of those give us a really good idea.
I think it's just important to, can you go back to the follicle scan? No? I was going
Why
to
would you do that?
Because that's what I like to do. With the follicle scan, we can't see the eggs within the follicles. I think that's something really important to point out. So it's only an idea as to the number of eggs that we may.
Oh no, I can look.
That we may expect to see. So some people, when they go for egg pickup, we might have had 10 follicles on scan, but we might only get 7 or 8 eggs. And people go, but I thought I had 10 eggs. This doesn't guarantee the number of eggs that we're going to collect, because we can't see that there are definitely eggs within those follicles.
I think that's a very good point. Now, most of the time, we would also do an ultrasound, a blood test at the same time, and we correlate both of those, because sometimes things happen that you can't see on the ultrasound scan, and so therefore we often combine it with some bloods. Now, at the end of your treatment, regardless of which treatment you've had, we then need to trigger off the ovulation. Now, the ovulation, this trigger injection, is what gets the eggs ready to be picked up. And pickup is then normally somewhere between 37 to 40 hours later. Now, the idea behind the trigger is that it avoids you getting sick by having too many eggs around, which is here, and avoids hyperstimulations, but it gets the eggs ready for the pickup. Now, that's usually done through the vagina, and most women prefer to have a light general anesthetic, and in our situation, that's done in our theatre, but you can have it done under local anesthetic with sedation. Both of them are really well tolerated. The procedure itself only takes about 7 minutes. You'll be there for a couple of hours all up, and you will need someone to drive you home afterwards, okay, but not before then.
Irrespective of whether you have a general or sedation, just
Yeah.
to clarify that. Can't drive home after you've had sedation.
Can't drive home. And so what you're seeing over here is an egg pickup, and then all of that follicle fluid, which is done with a tiny little needle through the vagina, is just collected by our scientists, and that's where the lab really comes in. And that's the important thing. And so while most of the work for an IVF cycle for you is done outside of the lab, in fact, the very important things are the things that happen within our laboratories, because that's where all the magic happens. And so this is what a laboratory looks like, though increasingly our labs are becoming much smaller. So what you can see over there, that's a lab in a box, if you like. So this is a completely self-contained, isolated system that allows us to, in fact, monitor your embryos through images, through time lapse, okay, and we watch the embryo grow. Even more so, if we can actually then analyze the embryo and see how well the embryo is performing, and that's using artificial intelligence to try and pick the best embryo out of all of them. At the same time, at the time of your egg pickup, your partner, or if you're using a donor, we would then be preparing sperm, okay? And that's usually collected in the lab, but it can also, as in the unit, but it can also be collected at home if people prefer that. Again, your specialist will tell you. Now, that's usually collected by masturbation, and for most guys, that's not too much of a problem, though it can sometimes cause some issues. There is a lot of anxiety associated with that as well. And of course, we understand that. And there are certainly instances where guys can't produce, and there are lots and lots of tricks that we have up our sleeves, none of which are terrible, that allow you then to produce a sperm sample. When it comes to bringing the egg and the sperm together, it can be done in two ways, really. Number one is we can allow the egg to fertilize naturally, and that's called IVF. And that's the standard term that everybody thinks about when we're talking about fertility. And here we allow about 4 eggs to be fertilized by about 100,000 sperm. And we would do that when the sperm is good enough and when the eggs are good enough. The alternative, which actually happens in more often than not in Australia, so just under 70% of all cycles in Australia are done with ICSI. And with ICSI, we take one perfect looking sperm and we inject it directly into the egg. Okay, so it's a slightly different process. In the lab, then your embryos grow. So on day 1, which is the fertilization day, we want to see that there is one nice cell here now, that the genetics of the sperm have combined with, or started to combine with, the genetics of the egg, and that we have an embryo, we see signs of fertilization. We would then continue to grow the embryo, and at that stage then it's called an embryo. As soon as fertilizations happen, we then continue to grow the embryo for the next 5 days. Now, not a huge amount of stuff happens on day 2. There is some division, but on day 3 is when we have our next milestone where we want to see our embryos having grown. And we want to see them somewhere between 6 to 8 cell stage at that point. We'll also grade your embryos, and different units have different grading systems. Now, those grading systems tell us how well the embryo is developing, but don't necessarily directly correlate with what the chance of pregnancy is. Day 4 is again an odd day. It's what's called a morula, where the embryos all the cells start talking to each other, and it looks like that little snowball that you can see over there. Day 5 is the day that we all want to get to, and that's where we have a blastocyst. And a blastocyst means that the embryo has now started developing into different cells. So there's an inner cell mass, and that's the bit that forms the pregnancy later on, or the baby. And then there's an outer cell mass, or an extracellular mass. And what that does is that forms the placenta and all of the membranes. Occasionally, actually, even before we put the embryos back, they start hatching because they have this little shell around them, okay? And that doesn't matter. They just start moving around the dish, but they don't tend to escape. The reason why we need to do IVF and not just take one egg and fertilize it is because human reproduction, unfortunately, by its very essence, is not particularly effective. So if you collect 9 eggs, then you might find that 2 of those are immature, or they're not quite ready. And so you then have 7 matures. Out of those 7 matures, then you might get 5 or 6 of them fertilizing. So that's only getting through day 1, and you've already lost about a third of all of your eggs. Out of those, then 3 or 4 might be dividing. And then hopefully by day 5, you will have one nice little embryo to transfer, and that's a blastocyst then. And then hopefully have 1 or 2 to 3s. So you can see from what's actually quite a large number of eggs, we actually wind up with a very small number of embryos, and that's just the nature of human reproduction.
I think it's important to say at this point in time too, not everyone's going to have 9 eggs. So if at the beginning of your cycle you only have 2 or 3 follicles, you're not going to end up with 9 eggs. This looks completely different for someone that has a lower ovarian reserve, or someone that actually has a higher ovarian reserve as well. Okay, and lower and higher don't necessarily mean better and worse.
No.
It's about the quality that we've got there.
Exactly. And, you know, with someone who's got follicle count where you see 30 follicles at the beginning of the cycle, we definitely don't want to bring all 30 of those eggs out. We want to aim for somewhere between 9 to 12 eggs. That's a really good number, because it's after quality that we're after rather than quantity, and that gives us the best chance of success. When it comes to the embryo transfer, and your unit will be communicating with you the whole way through this, when it comes to doing the embryo transfer, that's usually then done in the unit again. And again, this is not a big procedure. It's a little bit like a pap smear, the examination. It's not done under an anesthetic. And this is our embryo transfer room with us. And on your left-hand side, you can see the crib. And on the right-hand side, you see our lovely scientist and one of our IVF nurses that assist us in the transfer. And like in a pap smear, the embryos just put back into the right place. The remainder of our embryos, if you have any of them, are then frozen. And once they've been frozen, they're frozen in liquid nitrogen. They can stay frozen indefinitely, really, for millennia at least.
And they can be transported around too. So if you're leaving Sydney to escape to sunny Queensland where it's COVID free,
and why would you not? Yeah, exactly.
You can arrange for them to be transferred up to different units as well.
Of course, this is the crux of all of this, is the success rates. And the success rates depend very much on age, and they depend very much on your history. So in someone who is under the age of 30, we can expect pregnancy rates of somewhere between 30 to 40%. And in someone who is 45, on the other hand, we're expecting a 2% or in a 1 in 100 to 1 in 50 chance of falling pregnant. So even with IVF, we unfortunately cannot overcome the effects of age.
And that's per transfer as well.
And that's per transfer, correct. And so, Sam, the last element really is the weight. And so this is, of course, the most difficult and part of the heartbreaking, because you've got to do an embryo transfer. What are some of the tips that you tell people about that period of time?
it's hard. It becomes all-consuming, and people are counting down the days until they can do a pregnancy test at home. What I encourage our patients to do is to live life normally. That's easier said than done when you know that you've had an embryo put back, but it's to not allow this whole process to consume yourself. So if you've got a partner, do your date nights, enjoy yourselves. If you don't, then, you know, no alcohol, that's true. But, you know, a bit of self-care, a bit of downtime. If you're needing to have a little bit of time off from work, that's usually okay, and most specialists don't have a problem in writing you a certificate to have a day or so off if need be. Some people find that it is a little bit all-consuming whilst the weight is there. In saying that, though, there is no evidence to say that not going back to work or not continuing your daily lifestyle after you've had that embryo transfer increases your chances of success. So we don't expect you to go back to bed and lie in bed for 2 weeks. That's not going to increase your chance of getting pregnant. But yeah, continuing on with daily life, and like Anusch said, steering clear of alcohol. We do say whilst you're in this waiting period to treat yourself as if you are pregnant until we know otherwise.
Of course, during that time, you'll often be on a form of luteal support, so that means some progesterone, and so those are pessaries that are usually given, though occasionally it can be done as injections, but in Australia we normally give this as a pessary, so that's like a vaginal tablet that you use once a day, twice a day, or 3 times a day, and your specialist and your unit will advise you.
It is important to say, I guess, with that progesterone can mimic our PMS signs and symptoms, which can be very, very similar to early pregnancy symptoms as well. So for some people, they do read a little bit too much into those signs and symptoms, and I had a phone call today about this. It's about not feeling into each of those little twinges and everything that you've got, especially if we're doing what we call a fresh transfer, so 5 days after your IVF cycle, because your body's recovering from that IVF cycle too. So you are going to be bloated, you are going to be constipated, you are going to have little twinges here and
Welcome
there.
to pregnancy.
Welcome to pregnancy. That doesn't mean anything. The progesterone sometimes gives people tender breasts as well. So again, it's not thinking or overthinking those symptoms that you may be experiencing. They may be a sign of something good to come, but it may be the medication that you're on.
Yeah, and I think that's the important thing here. So we will then normally say that you have a blood test done, and then you ring us for the result, or we will call you. It depends on the unit. And at that point, then, if the test is positive, we will then talk to you about what you need to do. And in general, that would then mean stopping some of the tablets that you're on, like the pessaries and the progesterone. Though some units may tell you to continue those. We would then normally repeat the ultrasound, the blood test a week later, and then an ultrasound scan about 3 weeks later to confirm a pregnancy.
I think it's important also to say, trying not to do early pregnancy urine tests at home too early, because the trigger injection that we do give you does have the pregnancy hormone in it, the HCG, so it will actually show up as a false positive if you do that test too early.
And of course, if the test is negative, then we normally also stop things. And then the best thing we normally recommend is that you come and say hello to us, and we do a debrief. We run through the cycle, see what went well, what didn't work. We would go through the results and then talk about using your embryos that you have. Hopefully, if you've got some frozen embryos, you can then use them in a subsequent cycle. So that's how an IVF cycle runs, really, with those sort of stories. Of course, Corona has changed some of those sort of things, yeah. I think, as you would have seen back when COVID-19 was declared a pandemic, we had to close down a whole lot of units and we had to stop, but we're actually not expecting that at the moment. There are no plans to do that in any location, but it has meant that we've shifted a whole lot of things. And one of the things is that we've moved to lots and lots of telehealth and online bookings. And so what that means is the typical system was always that you would see the doctor in the rooms and you'd go in and make an appointment, and then you'd both come back to then have the consultation. we had seen even before the pandemic that most people were actually electronically savvy enough to go and do online bookings and electronic bookings, but the consultation still occurred in person. Of course, the evolution of that has now been that we now do lots and lots of telehealth. So that means that you can be at home, you can be at the time that suits you, and you can have your partner there, everybody zooming in, just like we're doing over here now, and that's how we're doing a very large number of our consultations. Unfortunately, scanning and monitoring cannot be done like that at the moment. Other things that are being done in our units is that we're using social distancing, and we're using all of the infection control parameters. And so that means also temperature and symptom checks when you arrive. So when you come to our place, for example, the first thing you're now greeted by is a big stop sign that says, wait here, let us scan your temperature and make sure that everything is okay.
Access granted.
Access granted. We're using masks in all of our healthcare facilities at the moment. And of course, we're encouraging vaccination. Very, very, very important. What can you do? Well, during your cycle, socially distancing is really important still. Wearing masks when you're in. These are the things that we talk about. You shouldn't be coming into your units if you've got a fever or a history of fever or acute respiratory symptoms, or if you've had a known contact. Don't come into the unit, but just ring and we will then tell you what you need to do. Even if you're in a cycle, don't come in. We limit the number of people in a unit, and of course that's caused some problems. You know, before we used to always have the partners coming in for embryo transfers, and they were always there for the egg pickup. Now, because we're trying to limit the number of people in a room, we're not doing that anymore. But your partners can usually Skype in. It also sometimes means that the sperm may be collected off-site, so it may be collected at home. And so a whole lot of things are being done outside of the unit. And of course, vaccination is really, really important again over here. Sam, what do you tell women about vaccination, COVID?
It is totally safe to get the vaccination, and if you are eligible, which everyone is, to go and get it. It doesn't matter whereabouts in your cycle you are. The only thing that we say in our unit, because we are temperature monitoring people, is to not have that vaccination too close to coming into the unit for anything, whether it's for a scan or whether it's a blood test or the actual pickup or transfer itself, just because we don't want you to have a low-grade fever, which is very, very normal post-vaccine, and not be able to come into the unit.
In fact, there is no evidence at all that vaccination has any negative effects either on your fertility or on the outcomes of the treatment. In fact, rather the reverse, we know that if you get coronavirus during pregnancy, particularly the Delta strain, that the outcomes can be really, really poor for pregnant women. And certainly a number of men who have been ill with coronavirus will experience significant problems afterwards, not only in terms of sperm production, but certainly with erectile dysfunction. So I think it's a very important thing that if you can, if you're able to, that vaccination will actually help in this process quite significantly.
The COVID vaccination as well isn't like your measles, mumps, rubella, or your chickenpox vaccine as well. You don't have to wait a month to be able to undergo a treatment cycle.
No, good point.
You can have it during the cycle, and you can have it whilst you're early pregnant as well.
Yep. In pregnancy, we would normally recommend something like the Pfizer, so the non-strained, the extracted vaccines, but all of those have been shown to be no problem at all. And that really completes our formal presentation for the day. So we are really happy to take any questions or anything online from any of you.
Well, thank you so much, Anusch and Sam. Hi again. That was fantastic. Thank you so much for such a comprehensive look, not just at the process of IVF, but the experience and what people can expect and what comes up for them. it's a really wonderful insight that I'm sure a lot of people are very grateful to have. So yes, we do have a few questions that have come through this week from our women's health community, the drop-in, but there's plenty of time tonight for questions. So if there's any questions that have come up for you at all throughout this, please feel free to drop them into the chat and I will ask them of Anusch and Sam. So I'll start off with some from our community, as you might be typing some in there into the chat box. I'll jump to the first one. So the first one is in relation to COVID, which we've just touched on. If someone has had COVID, so not the vax, but actually had COVID, will this impact their chances of IVF success?
So the answer to that is it depends on what's happened. Okay. So if you had COVID and you were well and you've recovered well and you've returned to normal lung function and there's been no damage, then there is no evidence that afterwards that there are any problems. But like I was saying before, is there's now increasing data to suggest that men who've actually had COVID-19, so not the vaccination, but actually the disease, actually develop quite significant dysfunction afterwards. There is no evidence of any long-term ovulatory defect if you have not had any major problems. Obviously, you've been in intensive care, if you've lost huge amounts of weight, if you've been really sick, it massively impacts your fertility like it does with anything else. But there doesn't appear to be any long-term effect at the moment that we know.
Okay, thank you.
I think it's important to just say on that, COVID, whilst it feels like it's been here forever, it only has been around for about, 18 months to 2 years. So we're just coming into that research space and looking at how it is starting to impact on those people as well. It's not just yep, we have the answer right now. It's one of those things that is ever evolving.
Evolving, for sure. I had a question that refers to the prenatal vitamins. We spoke, it was really good to hear that it isn't particularly a brand thing, it's around that they're still effective regardless. How far in advance does someone need to start, or do you recommend that someone starts on prenatal vitamins?
Yeah. As soon as they know that they're wanting to try and conceive. Very rarely is someone coming in to have IVF treatment. They don't just wake up one morning and go, great, I'm going to start IVF treatment. So as soon as they're at that point where they're thinking that they're wanting to start planning for a family, we would recommend that because, like I said, that build-up of that folic acid in the body helps support that neural tube development. So the longer we've been on it, the better. Especially with, I guess, I don't want to say older patients, but from a fertility perspective, older patients, we know that folic acid is really, really important.
We normally recommend at least 6 weeks, if you can, beforehand to be on some folic acid supplementation. But as Sam had said, in fact, lots of these vitamins are water soluble. So in fact, their levels change quite significantly, and really start as soon as you can. Would I stop someone in a cycle if they haven't been on folic acid for the last week or so? No, but we would absolutely recommend it. It's actually more important, in fact, that you have those stores in once you're pregnant, okay? And so as part of the treatment, while it's important, particularly if you're freezing eggs, it may be that in fact the pregnancy is sometime later on. So as soon as you can, preferably 6 weeks beforehand if we're planning.
Okay, and just on that, I'm not sure if I've got the pronunciation right, but I think it's Stamatula in our audience has asked, in regards to prenatal vitamins, are there any recommendations for men? And I guess that means, should they be taking anything? And if so, what, how long, etc.?
Yeah, well, it takes 2 people to make a baby at least, sometimes a whole unit, but at least it takes 2 people to do that. And the sperm health is just as important as the egg health. And so we do recommend that men, all of the things that Sam was talking about for women, in fact, pertain to guys as well. And that's why we usually see both of them together. And men should be on some preconception vitamins as well. And there are a number of brands out there. And again, these are antioxidant type of medications that particularly seem to help with assisted reproduction.
I think it's important to look at it as if you are in a couple and going through this process together, having that healthy lifestyle together is one thing that really helps both patients going through it support each other. I do know that when the female is being really, really healthy, but the male partner is potentially going out on bucks nights all of those sorts of things, it does cause a little bit of friction because the female feels like it's all on her, and like Anusch said, we know that fertility takes two to tango, and so I think having that kind of relationship where you are both going for that same goal does help with the support side of things, and reducing that emotional stress throughout the cycle as well.
Yeah, really well said. It is about that support in lots of different ways that partners can support each other through the journey. Someone has asked us from the community, they've said that they've been trying to fall pregnant for 8 months. The question is, how long should they try naturally before thinking about IVF?
Oh my God, that's a really, really good question, but that is a very big answer. So
we don't know who they are or how old they are or anything like that. I think very general.
Right. That's what it is. I think there is, while you can take some things and some generalizations, and I'm going to make some huge generalizations in a second.
Sure.
I think if you're worried at all, the best thing is to speak to your GP as the very first person, because in some situations we would say, look, you need to be doing IVF from the moment that I see you, okay? And in some situations you wait. So in general, under the age of 35, provided that the female or the woman is healthy, that you've got regular cycles, that there are no pre-existing conditions, and that the man is healthy, we would normally say 12 months. If you're over the age of 35, we would normally say 6 months is a reasonable amount of time. If you're over the age of 40, I would actually be starting to have some conversations with your GP right from the start. Now, that doesn't mean that you would need to have treatment immediately, but we would definitely assess. If you have irregular periods, don't wait at all, okay? Go and see someone, there's no point. If you can't have sex, don't wait, okay? If you have a pre-existing condition, for example, if you've been, and that's of course what I do, I'm an endometriosis specialist. If you have endometriosis, then we normally say 6 months at any age group is the most that we would say before you come and say hello to us and see us. If your partner knows that there's no sperm, don't wait. So I think for all of those sort of reasons,
if you're a same-sex couple, don't wait.
If you're a same-sex couple, don't wait. It's going to be a little bit harder without some assistance. So in all of those sort of situations, come and say hello to us, and we can actually do a little risk matrix and say, look, this is what you should do, this is where you shouldn't. And we talked about tele. Sam does telehealth consultations all the time. Getting access to a fertility specialist and to the right advice has actually never been easier than now. They're easy, they're straightforward. It's a consultation that you can have over tele, just like we are having over here now.
And most GPs as well, if they don't know a lot about.
So it sounds like in some ways, a bit of a silver lining.
Yeah, you're correct.
Definitely. A lot of GPs, if they don't know a lot about fertility, I will quite often get calls from their practice as well, asking about what sort of tests they should be looking at doing for their patients who are coming in for an initial assessment as well. So there's lots of access to gaining some of that basic information, and not waiting right until you're at that IVF point.
Well, what sounds great is that it sounds like people don't need to have made the decision themselves, that that's what they need to do, that you guys are very much part of that process in deciding, okay, where are you at, what are your options? It's an exploratory thing. Whether or not they decide to go ahead and when is another question.
I think you're right. And I think we started this as saying, look, you've decided that you're going to do IVF. But in fact, modern medicine is very much, we have a discussion together with the patient, with your needs, your expectations, and we come to decisions together as to how we manage what works right for you. What is right for someone is not right for somebody else. And there are no longer any black and white answers with all of those sort of things. So some people may mean that they will go to IVF very quickly. For some people, IVF is just not an option. And in a fertility unit like we run, there are lots and lots of other options other than IVF. And the premise of this was, of course, just demystifying IVF. But
Sure.
remember that very few women actually need IVF to conceive. Most women don't.
Yeah, excellent point. Thank you so much. So we've had a bit more of a technical question in regards to embryo freezing. Azin has asked, what is the difference between embryo freezing on day 3 and 5?
2 days. Okay. So the difference.
That was easy.
Yeah, but the difference is on day 3, the embryo is somewhere between 6 and 8 cell stage. Okay. At that stage, the embryos are these beautiful little balloons. The embryo consists of these 6 to 8 little balloons that are encased. They sort of look a little bit like the balloons that kids have when they're walking around with them. At that point, the embryo has been running purely on the power of the female egg. They really haven't been dependent on the sperm at all. So while the embryo may look beautiful at that stage, it actually doesn't tell us that it can switch on the genetics of the embryo, because that only happens after day 3. So up until day 3, it runs purely under the power of the egg. It's only that both the sperm and the egg start playing once you get beyond day 3. So day 5, when we have a blastocyst, we really know that this actually has a capacity to ever make a baby. On day 5, the embryo consists of hundreds of cells. So it's gone from 1 cell on day 1 to hundreds of cells in 5 days. It is just the most incredible growth to see. And at that stage, then you can actually give a much greater prediction as to whether or not this is going to be a good pregnancy, or whether it's going to result in a pregnancy at all. The other issue is that the freezing now on day 3 and day 5 is very different. We used to do everything on day 3, and you would wind up with, 7 frozen embryos that you'd put back one at a time, knowing that only 1 or 2 of them actually ever have the capacity to make a baby. And we used to slowly freeze them all in batches. What we now do is we grow them through to day 5, knowing that while we have a much smaller number of embryos, in fact, the chance of conceiving with an embryo, if it makes it through to day 5, is much, much higher. And we now no longer slow freeze them, we vitrify them. So we actually snap freeze them, if you like, and that happens literally within a split second. And they're stored at minus 197 degrees in our tanks, and they can stay like that for millennia. They will literally last forever. Now in Australia, we don't allow that. We make you make a decision after 5 years, and you can then extend it for another 5, and then again, if there's a need to. But most women would have used their embryos within that 10-year time frame.
Okay, excellent. It's incredible how much innovation continues to be in the space and evolution around the process.
What has happened over the last 20 years in this space, or in fact, since even over the last few years, things have changed enormously. And we're very lucky that Australia, we have a very, very high pregnancy rate with a very, very low complication rate overall.
Definitely. And it would definitely keep you guys on your toes, I guess, with so many changes. It would always be a very interesting space to work in for that alone.
Confusing for people sometimes when you read, because you're reading, in fact, material that particularly pertains to the US and Europe, and they are completely different, very different way of managing things. Costs are significantly higher. Pregnancy rates in general are lower, which is why they put many more embryos back. And that's one of the things that we get Australia, is the pioneers with the single embryo, because we know that 1 baby does so much better than 2 or 3, and the costs are significantly lower and the success rates are higher. So you can't really compare what happens overseas sometimes with what we would see in Australia.
I think also too, people that have done a cycle, potentially 3 years ago and were fortunate enough to have a pregnancy and have a baby, and then come back to do a second transfer, in that space of time, there's a whole lot of research that has changed. And so even for some of our patients that have done IVF before, it's hard for them to wrap their heads around why we might have changed what we used to do, because all that research has happened in such a short space of time. It is an area that is just forever changing.
Of course, that's such an interesting, it's a situation that I'm sure a lot of parents would be in, giving it a couple of years potentially between each child. And really interesting point around doing research. I'm sure people are wanting to delve a lot into research around IVF, but important to kind of look at the source and the date of that information as well. We're going to put some, we already have put some links in the chat box to Virtus Health and IVF Australia, where there are lots of great articles and blog posts as well. So that would also be an important thing if people are wanting to do a bit more reading, to have a look at those resources there, and we'll share them again at the end of the event. We've just got a couple of more questions we'll try to squeeze in before we wrap up in a minute or two. One question that came through again from Stamatula was, when IVF fails, what are some of the main reasons and what stage is it most likely to occur?
Oh yes, look, that's again a difficult question because it has a very long answer.
Okay.
This is part of the debrief that we were saying, that I think it's, while it's often nice to think, okay, can I just do another cycle or another cycle? It's actually really important to understand why it didn't work, because it alters what I would do. And so in essence, the problem is either the embryo or the environment of the embryo. But what makes up each one of those are a massive group of factors. And it's trying to tease all of those out is what we would do in a cycle. Most commonly, the problems relate to the embryo. Much less likely is it to the environment. But the problem is, of course, the embryo, we have much less capacity to influence, whereas the environment we do. And that puts so much pressure on women. It makes people think look, this didn't work because I had 2 cups of coffee when I should have only had 1, or I didn't watch my food, and I exercised too much. And I think this is the terrible thing about this. While we think a lifestyle is really, really important, if it doesn't work, it's not your fault. Mostly it just wasn't meant to be. But occasionally there are problems and there are issues. And that's why that debrief or that review after an IVF cycle to see what went okay, what wasn't right, what are the reasons, is really, really important. And your specialist and your unit will give you an opportunity to review all of that. Now, we also understand that people want to go, oh my God, people deal with grief in different ways. And for some people, dealing with grief means moving on. And we allow people to move on, but only within a ring fence. So if you're moving outside of things that are a problem, we will stop you normally and say, look, hey, we need to talk about this, because being on a merry-go-round of doing cycle after cycle after cycle is no good. And we don't recommend that.
Yeah, and I think also it's important to understand that whilst we have lots of things that we can look into and lots of testing that we can do of either the embryo or the uterus or investigative surgery or anything like that, sometimes there's not an answer. Sometimes it's unexplained. And I think that can be the most frustrating thing for the patient, but also us as the treating team. You've got all of these factors. You might have a tested embryo or a genetically tested embryo that is nice and normal as far as our testing can say. We've got the perfect environment to put the embryo back into, but for some reason it just doesn't happen, and that in itself can be quite hard for people to wrap their heads around.
Yeah, thank you so much. Really appreciate you sort of talking through that experience and what it looks like for some people, so they get a better understanding of that should that occur. Look, that's pretty much all we have time for this evening. Gosh, so many great questions that have come through, but thank you so much, Professor Yazdani and Nurse Sam Costa. It's been wonderful and so enlightening having you along tonight. So I just want to say thank you so much on behalf of the entire Drop-In community for your time.
It was a pleasure. Wonderful. Thank you very much for that.
Thank you. So I'd also like to offer a big thanks to all of our attendees for your time and your questions.